Good morning, and it's warm up here too. I'm very honored to be here to present on behalf of my co-author, Peggy Allred. In the Journal of the American Osteopathic Association in September 2002 and again in 2007, Christine Bruce, with a Master of Divinity and a licensed marriage and family therapist, discussed the grief process as it applies to the patient, to the family, and also to the healthcare provider. Her review of the major theories of grief and loss, as well as some identifying issues and recommendations, was an excellent basis for this descriptive research project. How ALS treatment teams deal with cumulative loss and reinvest in each new patient has been a topic of many venues. I've discussed it with many colleagues in these meetings. My colleague and I chose to research the literature regarding healthcare teams in self-care, and as a result, had the fire alarm go off. Do we need to obey the, okay. Okay, that's blue sky thinking, correct? Okay. As a result, we formulated a plan to explore the experiences of one team, Houston, Texas, Methodist-based MDA ALS Team Hope. The literature uses terms like wounded healer and burned out healthcare provider. It is a topic explored by every disease treatment group and most professional entities. The starting question for us was, what have we learned from others' explorations of this topic, and how is it translating to our ALS treatment teams? As we developed a set of questions for evaluating issues of provider grief, our formal and informal team and individual interventions, and self-care, we utilized the aspects from the following evidence-based theories or interventions, and I'm going to just briefly explain them. So we wanted to see how we were doing. So cognitive behavioral therapy is based on the premise of much of what we do is based on our thinking, and how we feel is determined by what we're thinking. Mindfulness, which is the basis, is centering and grounding ourselves within and in the present moment. It really focuses on being aware of all your incoming thoughts and feelings and kind of owning them in the moment, but not necessarily attaching or reacting to them. So you feel them, but then you can move forward. And lastly, critical incident stress debriefing, which we've probably heard about a lot with events around the world. And it can be controversial at times, but the idea is to debrief by going through a series of questions where you talk about how one cognitively remembers an event and then move into their feelings. So therefore, kind of decompressing or de-releasing that. So a set of 9 questions was asked to 22 team members, 6 males and 16 females. And I'm just going to briefly go through these questions. I apologize that I didn't put my email on the website, but we do have a poster tomorrow evening in which there will be the questions that in case anyone wants a copy of them. So these 9 questions were asked to 22 team members, 6 males and 16 females, and the results compiled along with basic demographic information. The questions were asked in personal private interviews by a member of the treatment team, which was myself, to provide a consistency and a reflective environment. The results showed that average length of time in healthcare for these people was 17 years. The amount of years that they specifically worked with individuals with ALS, an average of 10 years. Professional expertise included physicians, nurses, allied healthcare professionals, and clerical staff. Many of the group members did indicate that they knew about the formal and informal responses that we as a clinic team had to grief. Some of them included emails to the interdisciplinary team members to notify them of the death. A list of the deaths and the dates was in a private place at each monthly clinic for those who didn't necessarily get an email. There was a sympathy card illustrated here that was signed by all team members that's sent to every family. Many times team members reminisced about individuals and experiences with those individuals and their family members. Funeral visitation attendance by 1 or more team members when possible, often representing the team when only one of us was able to go. And we also discussed any trends or lessons or difficulties with patient death, including suggesting evaluations for change. Also included during this interview were individual and often private responses, tears, sharing with their families, individual cards and emails, journaling, exercise, One physician said to me, my husband and my son know when I've lost a patient because I'm very quiet and to myself that evening, and they just love me through it. Oftentimes, the level of the grief response was correlated to the depth of the relationship that healthcare team member had to the family and to the patient. Oftentimes also the similarity to themselves in age and gender, and a sudden unexpected death. One person said to me, you know, we expect the death and they're all hard, but those sudden ones are a different kind of hard. The grief response also appeared to increase with the frustration of a late diagnosis, the non-compliance to team recommendations, we were talking this morning about NIV, inappropriate treatment recommendations either before the patient arrived at the clinic or if the patient chooses to seek alternative treatments. Now, many of us in the room are probably all aware of the many theories of grief and loss, and there isn't one set of rules that applies, but we know that grief is normal. And not only because we need to grieve on our personal losses, we also need to grieve on our professional losses. And I don't know about you, I'm a little bit older, but I was trained that we were supposed to just gut it through and keep going and kind of distance ourselves from our patients. And then all of a sudden it started changing, so it was okay to get close to our patients. But we really didn't discuss what are we going to do now that we've allowed ourselves to be close to a patient, and how do we deal with that grief. Therapist Bruce also indicated that grief often activated basic issues frequently part of any helping profession, and that addressing these can be imperative if one is to maintain emotional health and resilience. They often include an attachment and loss for anyone who is empathetic, and I will swear upon a Bible that anyone in this room in the helping care profession has that gift of empathy. One of our professionals said, I remember this guy from Louisiana who brought Cracklin to every clinic. He was so upbeat, young, and edgy. He had friends who cared about him. His death really made me feel awful. He was coming so long, and I let him get in. I let him get in my soul. Oftentimes, the issue of frustration with altruistic goals. Many of us are told that our role is to heal, and here we are dealing with a degenerative disease where we feel often powerless to do the things that we'd like to. One neurologist said, it's tough to pick out one from so many. Each one is different, but one man in his late 20s had a real hard time accepting the diagnosis because he was so young. He came regularly, but he was always trying something new. He was taken advantage of. Others sapped his money as he was trying to reach for a perfect cure. I was so sad when he died, wishing that I had had more time, that there was something more I could do. Certainly our own personal issues and our death in our own personal life can be cumulative, but we can find that transference over into our professional lives. One of our clinicians said, I liked her. She and her daughter agreed like my mom and I did. She so reminded me of my mom. It's important to be aware that those emotions are going to happen, and it's not necessarily a bad thing as long as you're aware of it. One of my rules of thumb as a therapist is it's okay to cry with them as long as I'm not crying harder than they are. And lastly, certainly something that we've all experienced, which is grief overload. This terrible disease just makes us have to deal with grief over and over again. One of our neurologists said, there are so many, and after so many years, they just fuse together with one single message. Another physician, it gets harder. It feels often like I host their passing. Cumulative loss is so very hard. So as we reviewed the answers to the questions and I explored the experiences I had with each interview, our initial plan was to develop a set of suggestions for managing grief responses within our treatment teams. What I didn't expect to find that the process was and is as powerful as suggestions for grief protocol. I'm going to say that again. The process was and is as powerful as suggestions for a grief protocol. By using a member of one's own treatment team who lives and breathes working with ALS teams to ask the questions, an environment of safety and acceptance, at least in my experience, allowed team members to share their thoughts and their emotions. It became a cathartic experience for many, and I found themselves sharing with me days and weeks after they'd come up to me with a name. This was the person I was trying to tell you about, or a picture or a story of a patient who had touched them, who had changed them. I also began to understand that in the grief process, self-care is a component, but it's not the only component, as you can see in the slide here. I think an integrated approach is that you have the self-care, but what is equally as important and vital in avoiding burnout exhaustion is the health of the organization, the clinic and its leadership that not only allows but fosters and encourages grief expression, and whatever is needed to integrate each loss into goals of care for the next patient. To fall 7 times and stand up 8 is a Japanese proverb, but I think it really illustrates the analogy for resilience. Team members can learn and grow even in difficult times by choosing to remain connected to rather than disconnected from each other and what they define as their world and their experiences. From this descriptive study, our take-home message and suggestions would be for you to develop a brief set of questions, or you're welcome to use the ones that we've used. Choose someone to interview and assess what your team currently does after a patient death. Consider using someone who works with you rather than an internet questionnaire or an outside individual. And then look at your results. Layer the way you reinforce normal grief reactions and self-care that you use within your clinic and your treatment team. Consider the cultural aspects, the community norms, what your clinic looks like, what you're currently doing. You may be doing things that I haven't even suggested, and they may be working really wonderfully for you. Respect the privacy issues, or in America we call it the HIPAA police, but still allow your stories to be told, because they're not only the patient's life story, they are now part of your and my life story. Therapist Christine Bruce shares a suggestion. As healthcare professionals, we need time alone and time with others to feel and understand our losses. We need rest, relaxation, nourishment, and diversion to be replenished from the exhaustion of grief. We need a sense of security, trust, and hope in the future, gained by experience of being cared for. We need that which gives impetus and direction to life when it seems to be without meaning. We need lightheartedness, simple pleasure, and humor, which provides balance and relief from stress. I want to thank certainly my references and this author, Christine Bruce. I want to thank extremely my colleague, Peggy Allred, Dr. Peggy Allred from Cedars-Sinai, Program Manager and Research Administrator. And most of all, I'd like to thank Dr. Stanley Appel and the entire MDA ALS Team Hope for all their involvement with this. Thank you.